someone who leads the Gamma Knife program in radiosurgery in the Neurosurgical Oncology at UTHealth in Houston. He graduated from Mexico at the Universidad Anáhuac, and as you can see, he did his residency at McGovern Medical School and a fellowship in Memorial Sloan Kettering. He's got an extensive research background, and we're very happy to have him here for a conversation. Joyce, representing the surgery, will be helping me with this interview. So we're very excited. I'd like to remind your mission to cultivate and nurture and support the advancement of any Latino surgeon. That we can move forward together. And this is a team. I'm just the face of a big team who made this possible. And we're very excited to have you. These are our founders and our president. And we want to make sure that you are part of all the activities that we have inside the operating room, Cafecito, and sowing seeds and cosechando éxito and pass the baton. So make sure that you stay tuned for all the activities that we have. And we want to make sure that we grow as a professional society. We had a lot of traction. We are present in every major surgical meeting. And we'd like to thank all our partners and how they'll help us in our growth. Remember that our symposium is coming up, and we're very excited to see you there. A bunch of good research talks. So please register, join us. We'd love to see you there. And we also have a bunch of groups that you can join and volunteer. These groups are very dynamic. Like I said, we have representation today with the Latinos in neurosurgery, and we like to extend our invitation for you to join us. Just send us an email, and we'll be happy to connect you with the interest groups. And our motto is that anyone who's a Latino Surgical Society member should benefit from the programs that we have. And we have mentorship and program developments. As you can tell, we have great guests who are an example of how you can progress during your career. And that's what we want. And next September, we'll have our nomination if you want to be part of that. So please stay tuned. And I'd like to start welcoming Dr. Esquenazi. And thank you for your time. Thank you for being here with us. And one of the things that we like to share in this group is your testimony. We'll have a couple of questions. I promise you they won't be hard, but we like to extend our thanks to your time. And I know you're a pretty busy man, and thank you so much. And we're going to start a quick conversation to see how how we can get to know you better. So thank you for being with us.
Yeah, thank you, David. I really appreciate the invitation. It's a privilege to catch up with friends and students. I can see several of my students and people that work with me on the panel and as the participants. And thank you for the Latino Surgical Society as well. I'm happy to be here, and I'm looking forward to learn from you and your society and see how I can contribute in a better way.
Thank you so much. So let's start with the basics. I think these are all the questions that probably you get asked through your journey in the U.S. as a neurosurgeon. And how did you get interested in neurosurgery? Tell us a little bit about your upbringing and what brought you to the U.S. What made you decide to be a neurosurgeon and battle this hard battle? As we know, neurosurgery is one of the toughest specialties to get in for anyone who wants to try in this country. IMGs or graduates from this country is a really difficult specialty. So tell us more about you, Dr. Esquenazi.
Yeah, no question. I many times I was told that it would not be possible, that it was very competitive, and most of the time people would try to get you out of it. But that, in a way, made me more passionate about it. I did my medical school in Mexico, as you know, David. We were there together, and we had a chance to spend some time as rotations in the US. So I was fortunate to spend some time in Boston and Miami and other places as a fourth and fifth year medical student. And that's where I realized that, it was quite different, not in a better or worse way, but just different. I thought that such a specialty depends a lot on technology, and I was very interested in the nervous system and neurology, and I really like surgery. So I thought it would be a really good opportunity to combine both. and be able to operate on complex surgical interventions in the brain. I was very passionate about the brain initially, although neurosurgery has a significant portion of a spine component. And then when I came to the US, I found great mentors. I was able to participate as an observer and spend time with residents. I really enjoy the training program and the way the learning is done. And I decided that I wanted to kind of pursue that. On the other hand, I I sort of prepared myself for the exams when I was in medical school. So I was always reading the USMLE books. It was quite challenging at that time to get those books, and we didn't have those Kaplan courses or video recording. So it was just mostly reading and trying to get the books that the US people were using. And that's how I sort of prepare myself for the exams. And then yeah, I was always interested in research as well. I knew that it was an important component of academic medicine in the US. And I spent my last year of medical school doing a research project with in regards to pituitary tumors in the Centro Médico Nacional, which is a very large referral center where we looked at patients with acromegaly. And after that, I sort of reach out to people, and I ended up getting through the general surgery pathway. Sometimes it can be quite challenging to get right away into neurosurgery residency. Um, for me, because of I was a little bit of cycle when I finished, and by the time I got my step 3 or revalidation ECFMG certificate at that time, which I think is still is very similar up to this day, then I applied to a general surgery internship, and that's how I got to the Mayo Clinic. And at that time, I spent some time doing neurosurgery. I reinforced my love for neurosurgery, and I started to reach out to people. I applied, and I was very fortunate to go to the University of Texas, which was a program that was just starting at that time. Certainly for IMGs, it's very difficult to get into the premier programs. That doesn't mean it can't be done, but an opportunity opened up as a second year, and I fit really well because they really need someone with clinical expertise. And again, the rest is history. I spent a lot of time there. I was in New York later, and then they hired me as faculty, and I've been faculty at UT Houston for over 10 years now. So that's where I am right now. I've sort of been following a lot of you guys, the students. I have a lot of students from all over Latin America that come here and spend some time either as observers or research assistants, visitors, postdocs. I'm very involved with the Latino societies, and my goal is to help people and try to facilitate what whichever pathway I've already done so that others can follow. So that's in a nutshell what I've done, and I'm happy to answer questions. That doesn't mean that's the only way, but it worked out for me.
Thank you so much, Dr. Eskenazi, for that answer. It sounds like it's a very challenging pathway. And as you know, in today's meeting, we have a lot of IMGs that are here pursuing neurosurgery. So what advice would you give them as they navigate this process?
Yeah, certainly things have changed. And when I applied, it was, again, exceedingly competitive. It's not like it's been less competitive or more competitive, but you have to realize that you're not going to get right away into a neurosurgery specialty or any specialty whatsoever. I don't think anybody would get right away into even general surgery or any of the non-surgical specialties these days, unless you really try to apply to, family medicine and some of the specialties that there's a great need in the country. But for others, the competition is pretty high, and there has to be some sort of way of evaluating you in regards to the US graduates.
Yes, as you mentioned, Joyce, this is something that probably is the most challenging part. I've seen it in for all the IMGs that are in the panel and in the talk. I think one of the most challenging things is finding the pathway, and don't get frustrated if you don't go into the specialty right away. As Dr. Eskenazi was saying, it's usually for IMGs, is a different pathway. And even for students now, I see some students that are in good med schools and they have to sometimes take sometimes a year off or get involved very early in research.
Sorry about that. Yeah. So I was saying, David, that and things have changed in regards to how they would compare you to the U.S. graduates, right? And you have to understand that there's a responsibility and an obligation for the U.S. graduates that have committed, a lot of time for college, and many of them need to get loans to go to medical school, and the country needs to have a responsibility to be able to provide them with a residency program. That being said, there's always going to be room for spectacular applicants in any discipline. But how do you decide as a program director? And I can say that because I'm the associate program director from our program, where we have to decide, okay, is the person that is applying from abroad superior, or does he have something that would bring something very different or special to our program that would be complementary? Is it because he got great scores? Probably not, because everybody who goes into general surgery or any complex specialty, they all get very high scores. Is it that, they great at sports or they play instruments? Probably not, because everybody who's applying to these high-end specialties does something really neat. We've seen CVs that are exceedingly competitive, and in the past, the USMLE score was sort of a benchmark where it didn't really help you get into residency, but it could hurt you a bit. And what I mean by that is, let's say for neurosurgery, if you didn't have back then 250 or 255 was sort of the number that we looked at. If you were below that number, we didn't even look at the applications. But now everybody is scoring between 250 and 275. So that doesn't really matter what you scored. Everybody scored the same. Now, that went away. We don't have the scoring system anymore. So that's even more difficult for the IMGs, because as an IMG, you could have proved yourself to say, okay, I'm exceedingly dedicated. I can score well on boards. But that went away. So we have the pass or fail. Then the step 2, you got to score well. That's not going to put you into a residency program, but you have to do something different. And by doing something different, I mean spending some time in the US, doing either some research, could be basic science, translational, clinical trials, or working in a program doing something novel, device-related engineering, or having extensive clinical experience. And you may say, well, I train in my country. I'm already a neurosurgeon from Colombia, or I'm already a general surgeon from, Peru. Am I better positioned to repeat my residency? And that really doesn't give us an advantage either. When we see these applicants that already completed surgery, they're much older, and the system is very different. You graduating from a program anywhere else in the world doesn't mean that you are highly competitive in the US. So you need to really plan early of what you want to do if you want to come to the US. It's the same as for the local students. You need to start doing some research of contacting people and getting connected by the time you're a first-year medical school student. So I have medical students in undergrads that are already wanting to go into neurosurgery, working with us, or writing and thinking about what they want to do. And I recognize that's difficult because you don't always know exactly what you want to do, but some people do. And once you know that, reaching out, working with people, getting some publications on your background, improving your CV, perhaps getting some abstracts and traveling to some of the meetings, the American College of Surgery or the AANS, the Congress of Neurological Surgeons, connecting with people so that your CV will be strong enough. And then even at that point, you may not be superior to others, but that's helpful. And I always say there's 3 H's that we look into people. You want to be honest, hard worker, and humble. And those are key findings. So once you have that and you spend some time your chances improve, but again, you're in a disadvantage. Why? Because you're an IMG. But that doesn't mean that it can't be done. And you shouldn't be discouraged, but you have to recognize that you have to do something more than the local residents to get in. And that may mean 1 year extra, 2 years extra, 3, 4, 5 years. I talked to a resident, to a very nice applicant from Peru. It took him 5 years to get in. He got in. Some people may say, I'm going to just go back to my home and do residency there. That's not a problem. I have a student right now. I have 4 students right now from Latin America. One of them, just said, Dr. Esquenazi, I think I'm going to go and do neurosurgery residency in Mexico. And I support her. I said, not a problem. We're going to help you. This is going to be a great year for you. And that doesn't mean she's not going to be as successful. And that doesn't mean that she won't be able to come back if she wants to do subspecialty training and fellowship and eventually come here and work. But maybe she wasn't willing to live apart from her family and be by herself for 2, 3, 4 years without a guarantee that she will get in. It's a big commitment, not impossible, but you have to be perseverant.
What do you think about how the landscape has changed, about the numbers of applications increasing, how mentorship plays a role, and how there may be something that doesn't drive the applicants as far as the thickness of the CV, right? That's something that is very challenging when you're talking about applications, right? You're seeing like, no, it was before, when you probably applied, it was like the average number of publications was like 20, right? It's doubled to 40. Now it's 50, and it is almost impossible. Sometimes it takes you a couple of years as an attending to publish that number, right? And how mentorship plays a role in this case, your chances of having a good mentor and entering a program. How do you see that?
Certainly, the number of applicants from the international country IMGs has increased quite a bit. I think that number one, because of the USMLE scoring system. That used to be a self-limited step where, if you didn't score 240, 250, you would just don't even try to get into neurosurgery or general specialties. If you score 210, 220, you're unrealistic, not going to waste my time. But now, with the passing, everybody's like, okay, I'm going to try. Why not? I'm not in a disadvantage. Number two, it's much easier to publish these days than it used to be in the past. In the past, you want to publish, you got to go to the library, spend, 2 months finding each reference and write everything by yourself. Second, none of you guys English is a first language and neither my language. And for me to write a paper and issue was exceedingly complex. And I had to think 10 times every time I wrote a paragraph, and it wasn't even good enough. With AI and ChatGPT and whatnot, it's just so easy. I've seen a lot of these systematic reviews, and I know Pavel is on the line who does a lot of this, but I'm not in love with systematic reviews. We don't look at the thickness of the CV when we look at applicants. We've had an applicant recently that had 104 publications. That's really weird, and half the faculty in my program don't have even that. So the quality of the publications, are you just publishing, garbage? And most of the time it is. It's not just publishing. We match, we've very ranked a guy very highly this match had 6 or 7 publications. He had 1 in oncology. I mean, it's exceedingly difficult to do that. So he worked 3, 4 years on this project. The quality of the publications, and you know in what part of the work you did and what you learned about it and how you're going to apply those skills for your future career. That's what we care. So, but I also understand that you got to show something. And, I've also published some couple of systematic reviews, which have been highly cited, but not recommending just getting your name on low impact publications, because again, there's always a threshold. It's like when we see these guys that score 280, it's like, okay, you gotta make sure he's a normal guy, right? When you're in the 2-3 standard deviations, there may be something wrong with you. And we've had these applicants that graduated and they're 22 years old and they have all these CV and they're spectacular. But at that time, those applicants, it's a high risk, high reward situation. Some of them end up really bad. They're not mature enough. They don't have good social skills, communication skills. If you want to be a surgeon, you got to communicate effectively. You got to be able to speak. You got to be likable for your referrals and for your patients. But again, you have to find a balance. And there's no magic recipe for this. You just have to be the true version of yourself, work hard, have good grades in your school from the beginning. We even look at that. We had people that, come recently from Europe and this, and we're not sure how to look at the grading because the grading and the scores are very different in Mexico and whichever country compared to the US. So then we kind of figure out, we went and looked, and he's like, well, you're really mediocre during medical school, but you're not phenomenal doing research. But that's a problem. We don't want people that were mediocre at some point, and then now okay, I'm going to try to shine and do well for a couple of years. That's not good either. You have to be balanced. You have to be focused on what you want, and then just follow that, pursue that idea or that dream, be consistent, ask for mentors, connect yourself, go to meetings. This is what you guys doing, get into these webinars and participate in these societies. I think this is great opportunity for all of you guys. But again, the road is long but the reward is high.
Thank you.
Thank you. So you mentioned the importance of being a likable person as well as being someone that's consistent. I kind of want to segue into that because in general, neurosurgeons often face patients who have devastating diagnoses. Sometimes they have brain or spinal tumors or they need surgery for epilepsy. So how do you see the role of the neurosurgeon as an advocate for the patients and the communities we serve?
Yeah, definitely, most definitely. I myself, all I do is brain tumors, and 90% of them are malignant. So it's a top specialty, and we have support groups. But there's some sort of empathy to an extent where it doesn't affect your life, because you have to separate work and from your personal matters and from your feelings, and we all have complications, and I've learned, complications are horrible, particularly for surgeons, and we all have complications. You have to learn how to react to them, how to manage them, and but again, there has to be a separation between feelings and not get just completely scared where like, okay, now I'm not going to do that procedure anymore, or become more more conservative and not wanting to take the very complex cases, high risk cases. So, but I think for this panel that really doesn't matter. That's really beyond the scope of this. But certainly, as any surgeon, any physician should be patient advocate. Yeah.
One of the things that I think are very challenging from your specialty is how to effectively communicate such a complex system, right? I'm a surgical oncologist, and even sometimes communicating the basics of cancer. And then in your case, if you mix that with the complex, science and the complex pathophysiology that comes with neurosurgery, that's got to be fairly challenging. So what made you choose epilepsy and neuro-oncology, which kind of seem a little different in a way? One is more, I would say, functional, of course, devastating, and the other one has to do basically with life or death.
Yeah. I saw you put that on the flyer. I don't do epilepsy surgery anymore. I did some training because my specialty is brain tumors. But if you think about it, majority of the brain tumor patients present with seizures. So the techniques and the mapping that is needed to remove brain tumors is sort of comes from the epilepsy field. The mapping and the monitoring that we do with the electrodes and understanding seizures, and are we removing just the tumor or more than the tumor, trying to help with seizures. That's why I did as additional training. So while I don't take care of patients with medically refractory epilepsy, a lot, almost every single one of my patients has had a seizure or will have a seizure eventually. So I at this time, all I do is brain tumors. Um, and yeah, not easy, not I would say rewarding in a way. We can help quality of life, we can extend life, but again, 80% of what I do, not 80, but majority of the cases have either high-grade gliomas, which are not curable, or metastatic cancer, which is, again, not curable, controllable. But I also see a lot of patients with low-grade gliomas who can see their kids live and grow, and benign tumors as meningiomas, and some pituitary tumors that do really fairly well, some intraventricular pathology that once we do it, some patients may get cured. But again, it's very similar to your specialty, right? You're taking care of patients that have cancer, and you're trying to uh, get them back online and trying to get the best you can, and sometimes saving some people, sometimes extending life. And so it's a tough one, I think.
It is. It is. Mhm.
That sounds like a lot, but you're right. So, you did mention that you spent a lot of time in the OR as a neurosurgeon, of course. Can you describe maybe your teaching style in the OR?
Yeah, I mean that's everybody has a different teaching style. Not that one is better than the other one, but I'm pretty strict in the OR. I work in an academic center. I have a lot of help, a lot of residents that come with me. I always do cases with residents, most typically with chief residents, senior level residents, because of the complexity of the cases. But it's a progressive way of learning. Like, if you're not ready, if you're not prepared, you're not going to touch the, you're not going to remove brain tumor. You're not going to do much. But if you show, and then it's a repetition, it's very high risk. It's a balance of how much you let someone do and how much you're comfortable with someone doing, because sometimes there's no undoing, right? If I'm doing a craniotomy and I hurt a vein, I can't put the vein together. If I cause a contusion in the brain, I cannot remove the contusion. So those are that sometimes may not be clinically significant, but the room for error is almost non-existent. So it's a very long process. Even the chief residents, they may observe, but again, I don't think I think that's more advanced for like resident level of the teaching style. But teaching style for most of my partners is very similar. If you can do things, you're going to be able to learn, and uh, it, and we have very good success in our program. Exceedingly well-trained people that can do everything from spine, complex spine, to brain tumors, and they can be independent. But even when you graduate as a neurosurgeon, you're not expected to be able to do everything. And it's not different for general surgery. If you graduate from general surgery, you're not going to be able to do a lobectomy of the lung. You're not going to be able to do a uh, endoscopic or a fundoplication, and you're probably not going to be able to do a Whipple either. You've probably seen a couple of Whipples, you've seen some lobectomies, but you got to go into thoracic. And then within the thoracic, right, if you want to be specialized in robotics, then you have to do another fellowship. If you want to do liver resections and very complex anastomosis and so forth, you need experience, and even that takes time. So no one expects a neurosurgery graduate or even fellowship to be fully independent to take on complex cases. But do we expect that by year 4, year 5, you should be able to take care of any neurosurgical emergency? Anything that comes to, same for general surgery. If the patient comes with a pneumothorax or a bleeding vessel, you gotta resuscitate, do most general surgery procedures, most basic laparoscopic procedures. Same for neurosurgery. craniotomies for subdurals, intracerebral hemorrhages, management of hydrocephalus, management of spinal cord compression, cauda equina syndrome, stabilization of unstable fractures in the spine. And that's about it. But I don't expect my PGY-5 to be able to remove a medial sphenomeningioma or a glioma of the frontal lobe or a intraventricular tumor, because that's just not
It doesn't happen.
realistic. It
Yeah, it's
doesn't
not
happen.
realistic.
And as
Yeah.
a fresh resident, you don't want to be taking those cases because if it goes well, nobody's going to say anything. But if it goes wrong, everybody's going to have strong opinions and ask you why you're doing that. And yeah, I mean, I think my mentality, and at least for the way I am, is that I almost never done anything that I thought that there was someone better that could do it in my group. So,
Yeah.
initially, if I thought there was someone who was better than me, I would sort of show him the case, or at least, hey, I'm going to do this. Are you around? But, I do the same now for all my junior partners. I'm always around, but I don't want to see any young person taking something that I would probably wouldn't want my family member to have it done by that. And the system is very different. We're very subspecialized here. In other countries, in Mexico, and it's all over the place, the same. Everybody's an expert in everything. It unrealistic. And then the one day they're doing this, the other next day they're doing something else, and the outcomes are just not good. The patients don't do good, and it's not even good for the surgeon either. But I understand that the economics on that and the logistics is a very different healthcare system.
Yeah.
Yeah.
And also, I think one of the challenges is like when you're teaching someone is also learning about the ownership of the patient, right? A lot of shows with, how much you're going to be prepared for a case, like you said, and how much you own the patient. And that's something that translates to your life as an attending. And that's something that probably, I would say for the newer generations, showing ownership is probably one of the things that as an attending you value the most, and you let that person kind of take on cases because they're going to put the same effort in the OR and outside the OR. So that's a
Yes,
that's a great
that's a
point.
great point. Knowing what you're going to do, seeing the patient, rounding on the patient afterwards, understanding the pathology, those are things that I can tell you I pick up in 2 minutes. I mean, 1 minute I know if he knows what we're doing, if he was prepared, if he understands the case or not. And sometimes even neurosurgery, not everybody's interested. We have a lot of applicants and residents that want to do private practice, they want to do spine, general neurosurgery, and um, you may say that, yeah, sure, I have the responsibility to show everybody the same, but my level of investment is much higher for someone who I know who's going to end up doing academic neurosurgery, and that I rather spend a lot of time teaching him, and that may just be me, but I honestly don't have any interest whatsoever in training any more neurosurgeons to go to private practice. That's just me. But and now, yes, I have to train people to go to the community and be safe, but in my mind, a neurosurgeon in the community shouldn't be doing gliomas or complex brain tumors. But that's a personal point of view.
And if you could, based on all these experiences, given the fact that systems and medical systems and in two different countries, and what kind of advice would you give to your younger self, right? If you go back to 15, 20 years ago, and something, what advice would you give your younger self if you were back on time and tell you like do this, or don't do this, or I would better go this route?
Yeah, that's a good question. And and I was listening to a podcast, I think it was Scott Galloway or someone, where if you have someone who's uh, let's say very wealthy and he's already succeeded in business, and then you're starting, and he would say, oh, don't worry about it too much, enjoy life. Well, that's not going to work, because the people that tell you that is because they already succeeded or they're already wealthy. And to get to that point, they had to do a lot of things that now they're recommending you not to do. So I wouldn't tell you, oh, don't, enjoy life, or don't work too hard, or spend more time doing something else. I, I didn't do any of that, but, obviously I would have liked to, but I don't know if I would have done that, I would be here today. But one thing, maybe you don't want to try to, you know, be so an expert in so many things, or try to get yourself into so many different things. Maybe from earlier, I should have focused on a couple of things rather than so many things. Eventually, you're going to end up doing a couple of things, and you want to find a niche. Uh, but just be focused and
Is that what you
targeted.
tell yourself? That's what you would tell yourself? You think you were a little bit trying to just get in and
A
take
little
big
bit, a
chunks of
little
life?
bit, a little bit. Try to get my hands in so many things that may not necessarily end up summing in the same way. Maybe focusing more on a couple of things on a deeper level, and that's something that I still, to this day, I'm enrolling. I mean, I do like clinical trials and basic science, translational research, and I'm all of this. But as I've become, more senior, I recognize that and saying no to some things and focusing more on particularly subspecialty and targeted research. And once you do that, then you become even more an expert in that. So that's the only thing that I would advise. But uh,
That's a good one. We're all faulty of that. I can tell you, I think, especially in academic medicine, we are all trying to get a piece of everything, research, administrative and,
yeah,
meetings and things like that. So I think that's also an advice that I would give I sometimes give it to myself even now.
yeah.
But Joyce, you have a question.
Yeah, so it sounds like everything is pretty busy between research, academics, OR time. So how do you achieve that work-life balance? What's your life like outside of the OR?
So, let's say today I had meetings from 7 to 9 a.m. Then I had clinic from 9 to 4, 5 p.m. That then I rounded. Today is my non-surgical day. Uh, that's why I have, can do webinars at night and that. And then I got home, I saw my kids for 40 minutes. Then I got into the webinar here. And then I have a tennis match tonight at 8:30 to 10:30 p.m. So, I get home by 11, and then I have M&M tomorrow, 6:45, 7. So it is tough. And then I have 3 cases tomorrow. So it's going to be all day in the OR. Uh, but to be productive, and you have to build teams, you have to rely on people. I mean, I have a team of people and many medical students and postdocs that are doing experiments and that are writing papers and helping with presentations, and they get a lot of the credit for almost everything. But my job is sort of to guide them and manage the team. And I have residents rounding and seeing patients and taking care of a lot of the people that I operate. And we have MAs and NPs. So it's more of a managing the team. I'm not doing all of it, right? I'm presenting you know, studies on mice and doing experiments on animals, implanting tumors. I mean, last time I went into the animal facility, it's been like 5 years. So it's not like I'm doing those animal experiments, but I'm looking at what they're doing and looking at the results. And same for the clinical projects. I'm residents and people that are doing the job, and I'm guiding them. I'm helping with the connections and writing emails to collaborators in Germany and Europe and several groups that we participate with data collection. But I'm not sitting collecting the data. Uh, so that's something I learned recently, the last few years, and I think I've become quite effective at doing that. while recognizing the effort from the people that need to get promoted or that need to get some credit. But, I have little kids now, and I like to spend at least a weekend. Like this weekend, I'm on call, but I'm going to go to the hospital for a couple of hours and, spend some time with my family and try to exercise at night as much as I can. I know, David, he's a full Ironman. So you should ask how he does it. I don't know. I wish I could do an Olympic Ironman or something.
I- I'm not a neurosurgeon, but you're right. I think
Yeah.
one of the things that happens with our with our life in medicine, and I see all over the place. You have med students, INGs, you have residents in this panel, and I think your job as you progress and you're being successful relies a lot on your ability to manage and your ability to be organized and your ability to be a leader. And I know that's something that probably you guys think that it's something that is just for the people who want to be chairmen, or you want to be, even if you go to any practice that you're not going to be heavy involved in research, you're going to be a leader at some point of your residents. You're going to be a leader of your clinic staff. So that's something that you mentioned that I think is very important about how you become a manager, an effective manager. And I think that's underestimated when you're training that part. Sometimes you don't develop it, right? I think everybody's faulty of that. Like when you're training, when you're getting your skills up, and you do not focus on developing certain leadership skills or certain managerial skills that you should be working on, and you're actually actively building without you noticing. But that's something that is a very important tool for your future.
Yeah, no question about that. You develop those skills when you're a medical student. Some of you guys are already organizing these webinars. That's a leadership position. You get into residency, you're going to be managing your junior residents and your interns and your medical students. And some people are really good at that. Uh, some people don't like it, and some people are just completely not good at it. And you don't have to be you don't have to be involved in organized neurosurgery. Most of the things that I do they're not even part of my job. I mean, organizing a humongous dinner at the annual neurosurgery meeting, and nobody asked me to do that. Nobody, you know, there's not really, I'm in a place that many of my colleagues don't publish, don't do any research, and it's not an obligation. It is at some sort for promotion and those things, but to a certain degree, you can get promoted with a couple of publications, but you don't need grants or though. So it's on a personal basis, on a personal desire to improve yourself, to leave a mark, and at least you know to build a legacy or just help people. I mean, I at this time what I enjoy the most is just helping a lot of you guys, and very excited when one of my residents or my former students match and I get letters that, I'm doing this. I got into medical school now. I mean, I got kids, 16-year-old kids that come spend some time with us, and it's like, wow. And then you see them 5, 6, 8 years later, and then they're already doing residency somewhere. And that's really nice to connect with people in that way. And all over the world, and particularly with Latin America.
Thank you so
Thank you.
much. That
Sorry,
was
Joyce. Yeah, we have a couple of questions from the audience. So why don't you ask them both?
Yeah, so we have a question here in the audience. It seems like it was partially answered maybe in the past, but by any chance, do you think that completing a surgical residency in your home country provides an advantage, or do you think it's more challenging to train surgeons who have already done previous training?
I don't think it gives you an advantage. It may be a little bit more difficult to train people that already have a mindset and a specific way of doing things. That doesn't mean that you're not you're not going to be trainable. So what it can do for you is that it can potentially allow you to take a spot that they got to open up for a specific reason. If someone quit from a program and you have general surgery background or some clinical background and at least some clinical experience in the US, you can jump into one of those positions. We trained a resident, we graduated 3 years ago, no, last year, Elvira, who was a fully trained surgeon in England. Then we graduated Ali about 7 years ago. He's a fully trained surgeon in Syria. And but those were we didn't match them from the beginning. They kind of filled some positions that were available, and because they have already done fellowships in the US, therefore they were eligible and get maybe, some accreditation for their training, maybe 1 or 2 years, but they really had to repeat the entire thing.
Thank
I
you. We
would
have a
I wouldn't do that if I wanted to come here, I wouldn't do that.
yeah. Yeah, it's tough. We have people who go through that, and it's a whole journey. And a lot of these things also we have to recognize in Latin America and other countries in Europe have to do with sometimes social issues, right? Safety for your country, things like
Right.
that. And that's something that also has to recognize. We have a couple of questions also. What are some red flags or deal breakers on an applicant? Things that I know you partially mentioned your two, three H's, so I'm sure those are deal breakers. But any other deal breakers on an applicant, red flags? And then we have another one after that Joyce is going to ask, but tell us a little bit about it.
Not really in terms of the CV, but once you meet people, if they're sort of some applicants that are a little bit arrogant during the interview or think they maybe too smart, that we don't want that. We just want to train normal people. We just want to enjoy the time, and we want you to enjoy the time. Um, Obviously, when you see someone with 100 and plus publications, you have to figure out how is that possible, right? Is he doing the publications? Is someone else putting on them? Is the quality of the publications good? Uh, but mostly based on recommendations. Recommendations are important. That you work with someone that is reputable or that has a strong opinions about your performance, that's really helpful.
Okay, thank you. And another question we have here from the audience is, from a research fellow perspective, what would make one stand out?
From a research fellow, well, someone that has a lot of initiation, someone who's self-driven. If I'm giving you a project and I have an idea, and you come and tell me, I already did this, I already looked into the literature, I already look into the database, I already analyzed this is what I found, we should write this as such. I'm pretty impressed with that. If I tell you, oh, why don't you look into this, and you're like, okay, I look into this, but you know, this is what I found. Okay, now I have to tell you, well, why don't you do this? And you're like, okay, I already did. What's next? So I'm not holding hands to anybody. I I'm pretty hands off, and it's the same with residents, right? If you tell, oh, I have a patient came to the ER, his GCS is 7, he has a 9 millimeter subdural, and then they send me a video on the phone of the scan, because before we didn't even have that ability, right? They had to describe the scan, and then in my mind I put in the image of the scan that they're describing. So I have to tell them, okay, so no, I don't want that. I want a phone call that says, this patient has this is his coagulation studies, this is what we're doing. We need to take him to the operating room for this reason. Or we're not going to take him to the room, we're going to put an ICP monitor and this. And then, do you agree with that plan? And I would say, yes, thank you. Or I would say, I disagree with your plan. And I would explain why I disagree with the plan. So it's just an example of the clinical perspective and the research perspective. You just have to be self-driven and not expect anybody to hold your hands, at least for me.
Thank you. We have a couple more questions. So one of them is about but thank you for all the audience for asking these interesting questions, Dr. Esquenazi. They're loving your talk. And for some,
Oh,
I think we have a couple of talks about questions about things about hands-on internships and hands-on things. So that's probably something that we'll leave for probably connect with the Latinos in neurosurgery. But we have a couple of interesting ones. One of them is there's someone who's starting an internship. Barbara Alessandra Solano Silva is starting an internship in neurosurgery in the US. So what tips would you give him to make a good impression? I think you just partially answered that, like be proactive, kind of be insightful, be involved with your patients. But what other tips can you give someone?
yeah, just be there, be present, make sure the residents like you, be the first one to be there and the last one to go home. That's what they used to tell me. uh, ask questions. It's better to ask. You're not going to bother anybody. I mean, I had 2 students in my clinic today, and they're asking me, you know, simple questions, but at least I know they're there. They're not ghosting. And um, there's a limited amount of what you can do. And it's not very different with the medical students that are graduates from here, like the US graduates. We're not, even they say, okay, we can't scrub. That are we in a disadvantage? Honestly, I almost let I don't expect any medical student from the US to do much at all during surgery. So they're not gonna be, you guys not gonna be a significant disadvantage. It's more the off OR conversations after the surgery, or, oh, I read this, why you do this technique, just so that we know that you're there and that you're interested and committed. Yeah.
You want to ask about the advice, the Ronald Hernandez?
Yes. So basically what we wanted to know also is in general, I'm sorry, just give me one moment for the advice question.
It's like, what do you think was the best advice that you received in your life?
Right.
There's a very famous neurosurgeon, Mitch Berger. He once told me, I was just walking, I think, in the meeting in San Diego, and he just said, Joshua, just keep your nose down and take notes. That's all he said. So, that's what I've done for for 13 years. And then he said, before you know, you'll be giving all these talks and you'll be on those podiums, and that's it. So just keep your nose down and take some notes.
That's a good lesson in being humble and just take notes and follow the lead. We had a wonderful time with you, Dr. Esquenazi. We really appreciate your time, the value of your testimony, your honesty. As a good neurosurgeon, you were very blunt, straight to the point, and honest. I appreciate that. It was a great conversation, and I think
Yeah.
a lot of the group appreciates the journeys and the honesty, and giving hope for the ability to succeed in such a difficult specialty. We admire your persistence. We admire your hard work, and
My
definitely we're
pleasure.
very proud of you as a Latino surgeon, and that you're standing for us, and you're doing such a wonderful job. And we have a groups of interest. Please write us. We'll if you have anything that you want us to relate to Dr. Eskenazi, Joyce can help us, and we'll put Joyce in contact with you. And thank you
Yeah,
for all the mentorship. I know somebody mentioned
for
Pierre
sure.
Pavel, a great guy who promotes a really good vibe in neurosurgery, a good advice. And I often don't give any props to any social media celebrities, but when someone's with such honesty
Okay.
are working and putting the face out there with the good and the bads, and showing what an example of someone who works really hard. I like to appreciate it because he helped us promote this webinar also. And welcome to the Latino Society. I
Yeah,
hope you
my
can join
pleasure.
us.
Yeah, well, absolutely.
Our
I'm
fees are
happy.
not high. Our the group of interest
Sure.
will reach out to you, and
Sure.
thank you for your time.
Yeah, thank you, everyone. It's very nice to catch up with friends and students, and I wish everybody the best, and hopefully we'll catch up soon.